everyone. It's my honor I'm happy to share our recent work on SARS-CoV-2-specific T cells in the lung of COVID-19 patients. It's well established that SARS-CoV-2-specific T cells are Th1 dominant phenotype, and they are polyfunctional. They can produce cytokines like interferon gamma, TNF, and IL-2. And they can recognize a broad range of antigens, including structural proteins, non-structural protein, and accessory proteins. And we have known that early induced T cell responses contribute to better clinical outcomes. However, most of these results comes from the blood samples, but the battle is happening in the lungs. So what happened in the lungs? Our earlier animal study have shown that specific T cells in the lungs can help to clear the virus, and they play protective roles. But in COVID-19 patients' lungs, we can see that there are cytokine storms and diffuse lung damages, and we can see a lot of immune infiltrations, including myeloid cells, lymphocytes, including monocytes, macrophages, T cells, and B cells. And study also report that lung T cells coordinate with the inflammatory macrophages in the lungs to worsen the immunopathology. But due to the limited samples of the human lung samples, until now we know little about the specific T cells in the lung. So we asked two questions. First, what defines the phenotype and functional role of virus-specific T cells in the lung airways during infection? Second, does the peripheral T cell responses accurately mirror the compartmentalized response in the lung? So to answer this question, we stimulated paired BAF and PBMC samples, cells with SARS-CoV-2 peptides, and detect the specific T cell responses by intracellular cytokine staining. And the cells expressing interferon gamma were defined as specific T cells. And we can see here that specific T cell responses are significantly higher in the BAF than in blood. Even when we expanded the detection to a larger cohort of 159 patients, we can see that the T cell frequencies in the BAF increased over time, and the T cell responses in the blood were remain low and flat. And we further correlation analysis show that no correlation between the frequencies of virus-specific impaired BAF and PBMC samples. This suggested that peripheral T cell responses cannot predict the lung immunity. Then we further analyze the specific T cells in the BAF with the viral roles in the lung, and we can see that the frequencies of specific T cells in the BAF were negatively correlated with viral copies in the lung, and they are positively correlated with improved lung function and reduced systemic inflammation. All these are suggesting that the specific T cells in the lung are playing protective roles. And we also observed that specific T cells in the lung expressed higher interferon gamma in the bath. And these T cells can co-produce multiple cytokines, including interferon gamma, TNF, and IL-2, GM-CSF. They are more multifunctional. And this polyfunctionality were increased over time, suggesting that this multifunctionality were enhanced in the airway over the disease progression. Then we used a 29 color flow panel to dissect the phenotype of these specific T cells. And T cells can be separated to 9 distinct clusters, and specific T cells in the bath are mainly tissue-resident phenotype, and they are Th1-like, and they can produce multi-cytokines. And here we can see that the cells in the bath also express higher levels of tissue-resident markers, including CD103, CD69, CCR5, and the cells in the blood remain less activated. Then the single-cell RNA and TCR sequencing data revealed that about 20% of cells in the bath are T cells, and about 10% of these T cells are virus-specific. And here we can see that the specific T cells in the bath expanded highly in the bath. And transcriptomical analysis show that these specific T cells in the bath highly activated, and they are expressing more cytokines, and the TCR and mTOR signaling are upregulated, and these cells are glycolytic metabolic program. And what happened after the virus what happened to these cells after the virus are cleared? Here we can see that the frequency of the specific T cells are increased after the viral are cleared, and the cells transcriptome program also shifted after the virus cleared, and the interferon responses were downregulated, while the T cell activation, tissue migration, and cytokine production signaling are upregulated in the bath. And the transcriptional and protein level analysis shows that both of these bath-specific T cells turn into Th1-like and tissue-resident phenotype in the bath. Then we want to ask that whether these upregulated activated T cells in the bath induce more inflammation in the bath, in the lung. Then we detect the cytokine levels in the bath, and we can see that even after the virus were cleared, these specific T cells in the lung did not increase the inflammatory cytokines in the bath. And the CD206 positive alveolar macrophages frequency were increased after the virus were cleared. And this specific T cell and the crosstalk between these specific T cells and other lung cells were reduced after the virus was cleared. And all this suggesting that the specific T cell didn't induce more immune pathology in the lung after the virus was cleared. And in summary, in our work, find out that the SARS-CoV-2 specific T cells in the COVID-19 patients were highly activated, and they are clonally expanded and tissue resident. And the specific T cells in the lung are phenotypically different from the blood, from the periphery, and the blood response cannot reflect the lung immunity. And these specific T cells in the lung are critical for viral clearance and lung function improvement during infection. And I want to thank my mentor, Professor Jincun and Zhao Jinxian, and all the collaborators on this work. And we acknowledge the findings of NSFC and MOST. And thank you for ProImmu for holding this conference. I'm happy to take any question.
Very nice data. I have a question. The bronchoalveolar lavage at the beginning was done when the patients were still SARS-CoV-2 infected. Therefore, they will have an acute infection. Correct? You have done this longitudinal analysis.
Yeah.
So, and you were having basically cells when you said there was still SARS-CoV-2 infection. So it means that the study was done during acute infection or after, let's say, resolution? That's my first question. You understand? So it was done in patients with SARS-CoV-2 that have SARS-CoV-2 acute disease. That was the test.
Yeah.
And then the other one, when you say the frequency of SARS-CoV-2 T cells increase over time, was the same patients that was tested when it was resolved?
There is only one patient we get the follow-up samples. So most of the samples come from different patients. Okay. And the positive one are from the acute infection, early stage of acute infection, and those RNA negative groups come from the later stage of the infection.
So I was asking this because you were saying, oh, the frequency of SARS-CoV-2 T cells increase in the lung. Maybe what is decreasing is the quantity of inflammatory T cells that are present during the acute phase. That's my point. That's it. So I'm just saying that probably at the beginning, during the acute phase, you have a large influx of many cells, and then the antigen-specific cells probably are diluted in many other T cells. Then when the inflammation is gone, you have only the T cells that are antigen-specific. And that's why then you say, oh, the frequency is increasing. You probably have the data to see that. How many cells did you test every time? Anyway, doesn't matter.
Okay, thank you.